Good evening, everyone. Tonight's talk is presented by Dr. David Smith. He is an MIT-trained engineer who did his medical training at the University of Chicago. He has been a practicing physician for over 30 years. Dr. Smith is an orthopedic surgeon with Bone and Joint Physicians. They have multiple locations with offices in Oak Lawn, Orland Park, Flossmoor, and Calumet City. At the end of the presentation, Dr. Smith will answer as many of the questions that were submitted as time allows.
Well, tonight we're going to talk about some surgical options other than total knee replacement for arthritis. And I see a lot of patients who have went through the pills, the injections, the braces, physical therapy, and still having problems. And they're getting to that point where total knee is becoming an option for consideration. And tonight I'd like to just introduce a few other approaches. Sometimes the total knee is a bridge too far for some folks, at least at that stage of the arthritis they have. So we're going to talk about how the total knee is not always the total answer. And I want to introduce a unicondylar knee replacement as a possibility for some people. And this is something that when I was in training in the 70s that was very popular. Total knees at that time were not as reliable, and the unicondylar replacement was used more frequently, and actually I was always pleased with it in terms of the response I would see in patients. So we want to talk about that. Here's a picture showing a partial knee replacement. Basically comparing it to a total, you can see that it's quite a difference in the invasiveness of it. And of course that's not the only consideration, but let's talk a little more detail about how you come to this decision if you do decide to explore the possibility of surgery. So basically, most of us, if we're not in the business I'm in, you look at a knee problem as either pain or instability, it's giving out, or stiffness, it just doesn't bend like it used to, doesn't straighten out like it used to. And you start exploring. The question is, these three questions, which I try and answer for all my patients, which is, first, what's wrong? And the second, what can they do about it? What are the choices they have? And then the third is, how's it going to turn out? So that's what we're going to do, directing our talk tonight a little bit toward the partial knee replacement and as to which patients may benefit from it. So to answer that first question, what's wrong, we have to do some detective work. And that's gathering information, just like Sherlock did. History is really important. It's, for me, it's the distinction of little things like, does your knee bother you primarily on stairs, or does it bother you when you're walking and standing? Is it on one side of the knee more than the other? Or is it the entire joint that hurts, both on the big toe side and the little toe side? Physical exam is critical, particularly when we're thinking about a partial knee replacement. We need x-rays. We sometimes use ultrasound as well as MRI. Just a general idea about knee anatomy. Let's look at the major bones that are involved, the kneecap or patella, the femur. There's a joint between the patella and the kneecap, and this is particularly engaged when you're kneeling down, squatting, when you're going up and down stairs, climbing a ladder. But the old statement, where the rubber meets the road, where weight is transferred from one joint to another, from one bone to another in the knee joint, where the femur transmits weight to the tibia, we see this white material, and that's articular cartilage. And how healthy that is really is the bottom line as to how well the knee is going to do. Is that these additional little pads we see, the meniscus, with Super Bowl Sunday coming up, a lot of football fans will be hearing about athletes that have had a knee injury and perhaps torn the meniscus. So when we're talking about the knee, we think of these three compartments. The big toe side, which we're circling here, 90% of the arthritis I see really starts predominantly in the medial compartment. Patellofemoral joint, sometimes we do see isolated arthritis in that joint. We often can see it in combination with the medial compartment or big toe side, and then the lateral compartment. What is arthritis and what happens in an arthritic joint? This slide shows us a schematic of a knee. On the one side, we have bone, cartilage. We have a capsule, sort of the clothing that sits over the joint, and then there's a lining called synovium. This synovial membrane is what produces the fluid that provides lubrication to the joint. Now, fundamental is articular cartilage, this white icing or coating we see here. What happens in arthritis? Well, first the cartilage breaks down and particles come loose in the joint. Some of those become embedded in the lining of the joint, and it becomes thickened from chronic inflammation. The capsule responds with thickening. And it's just, if you think of the difference between wearing a light t-shirt to do some activities versus wearing a heavy leather jacket, well, the t-shirt on this side, the green capsule shown here is green, becomes thickened, and that tightens up the joint. That synovium produces more fluid, distends the joint, and can add to the pain. As the cartilage continues to wear off, the weight transmission that goes from the bone through the cartilage, and when that cartilage is defective, it overloads the bone, and you form this sclerosis. And sometimes you will develop even small holes in the bone called cysts. So this is sort of the progression of what happens. And what we're talking about is those patients where it's predominantly on one part of the knee, but not necessarily as severe on the other parts. So we can explore that through MRI, but also arthroscopy. And arthroscopy can play a vital role in two ways. One, in terms of investigation of the joint, and it has some purpose. If I've scoped a knee, and we'll do in a lot of patients I have who have arthritis, they've had that buildup of those wear particles, they've got inflammation in the joint, they've got some degenerative or wear and tear type tears in the meniscus. We'll go in and clean out that joint, and it does help some people. I'd say it's probably about 60% of the people that are scoped for arthritis will get some benefit. It might be short term, but it can be up to several years. And that information from that arthroscopy can help us decide whether or not the arthritis is primarily on one side of the joint, but not the other. I don't do that for every partial knee replacement I'm going to do, but it is helpful. And I think for the person who's deciding whether or not they're going to have the partial knee replacement and wants to try something less, this is outpatient surgery, it's worth considering. I know if I had arthritis in my knee and it was starting to bother me, I would certainly give serious consideration to arthroscopy for both purposes, both treatment and diagnosis. So this is sort of a little schematic again. It shows the articular cartilage covering the bone. We see the meniscus. What happens with arthritis? Well, you see bone spurs, you see this erosion of the cartilage. But most of the arthritis doesn't begin in all the compartments evenly. The other thing I look for when I'm examining a patient is the mechanical axis, how that lines up. And for many of my patients, I can see them walking into the exam room, and you can see how the knee's aligned. And in patients that have predominantly unicompartmental, in other words, one side of the femur tibial joint space is worn down, just in the same way if you let the air out of the tires on your car on one side, passenger or driver's side, the car is going to lean toward the side where the air has been let out of the tires. So when the cartilage wears out, that joint space narrows and the knee tends to lean. We call this varus, what you'd call bow-legged, I guess, in a non-medical terminology, or knock-kneed, or what we call valgus. So a valgus knee, the lateral or little toe side of cartilage is worn out, and in a varus knee, it's the medial side. And this shows the balance we were trying to show with the plumb bob on the initial picture. It should go from the center of the hip through the center of the knee through the center of the ankle. That's the alignment we'd like to maintain. So as we talk about partial knee replacement, we compare it to total knee replacement. And even a total knee is not one uniform type of device. And oftentimes patients only hear that the doctor's recommended a total knee. There are two distinct types in the primary, in other words, the first time someone's having a knee replacement. One's called a CR, cruciate retaining, the other's called a PS. A unicompartmental, what we're talking about tonight, the partial knee replacement, preserves the 4 major ligaments in your knee. The one on the big toe side is called the MCL or medial collateral. The one on the outside called the lateral collateral. The 2 cross ligaments called cruciates, ACL and PCL. All 4 of those are preserved, which leaves you with more natural anatomy. The CR knee, when I do a total knee, almost always I'm using the CR. Occasionally we have someone who's had lost the posterior cruciate ligament, and then we'll have to go to the PS. Some doctors start right with the PS total knee. So I think it's interesting for you, if you are considering that, to kind of know which one's being chosen. The results have looked at these 2 types of total knees, and over a large series of patients, it seems to produce nearly equal results. But my preference, if I was going to have a total knee, would certainly preserve as many ligaments as I could, and I would certainly want this over this, and I would take this uni over that if I could get it. In other words, if I fit the criteria. So again, we're leaving all the other parts of the knee untouched. In a sense, if only a third of your knee is affected primarily, why replace the entire joint surface of the lateral side and the patellofemoral side if just the medial is worn out? So again, medial is the big toe side, or what you think of as your inside. The lateral is the little toe side of the knee, and patellofemoral is the kneecap. So if the medial side wears down, you're going to become bow-legged, a little more bow-legged. Sometimes it's subtle, but sometimes it's more severe. And then the lateral, person becomes more knock-kneed. This is a classification system called the Allback, and it basically shows the stages in the development of the arthritis as it progresses. These are the patients, the 2 and 3 class, that are candidates for a partial knee replacement. Obviously, there are some borderline cases, and some physicians and surgeons will push the limits a little. Dr. Rapisi is one of the fellows I quote in some of these talks. He does some grade 4 lesions, and they don't produce as good results as the 2 and 3. So this is the primary group you're looking at. So again, the choice is, do you need this, or can we get away with just the partial? These are the kind of x-rays when I see a patient who's been complaining of knee pain. We've talked to them, examined them, get some x-rays, and I always get standing views. Sometimes patients come in and they'll tell me, oh, they brought x-rays that they've had done outside. And many times they're not standing x-rays, and it's so important to see that, because a knee that can look reasonable when it's not weight-bearing will show complete loss of joint space with standing. So this is the big toe side. The lateral side of the knee, the little toe side, has the fibula out here. So this is 80–90% of the arthritis I see has this pattern. But we do see as well patients who have the lateral side worn out. For either side, partial knee replacement is a possibility. Waiting till it's too late is not good. Left untreated, progression from unicompartment to tricompartment may occur. So I think just something to think about. I do see folks, and often do knee replacements in them, that have really let their knees progress to such a degree of deformity that they're compromising their outcomes, even with the total knee replacement. So it's a difficult decision for each person to make, but as that one slide showed, it's not just cartilage and bone, it's that surrounding capsule and soft tissue envelope. And as you let the arthritis progress over time, that becomes irreversibly changed, and and that's the same capsule you're going to have after the joint replacement. How does the unicondylar work? One of the purposes is to rebalance the knee, to redistribute stresses more evenly across the joint. How does it work out, or what's the clinical results? When you look at some studies that are done, this is a prospective study, meaning it was done ahead of time. It wasn't somebody who looked back over their cases, but was randomizing people, and I'm surprised that you get some people to do that, but basically it was patients who seemed to be good candidates for either a partial or a total. And what they saw in their unis was 71% patients rating it excellent and only 53% of the total knees. So this is something that we see, and I think most doctors who do both will certainly say that you see a lot more excellent results where the patient is very, very pleased in the unicompartmental over the total. Obviously, it's a different group of patients, but here they're comparing apples and apples, and they've got a higher results, 71% excellent versus 53% for the total. Well, how long do they hold up? Now, this is a little different than we see in most studies. Here it actually shows the unicompartmental lasting, or having a higher 15-year survival. Usually it's a little more tilted toward the totals lasting longer. How about younger patients having the uni? There's two classes of patients. We see, in a sense, the younger person who has primarily one side of the knee affected, and then we see the older people. Well, the younger person is going to be putting more load on it. They're more active. They have higher expectations. But even in that group, when you look at it, patients less than 65 at 11 years, 98% survival. You see price less than 60 years, 10-year survival, 90%. So there's certainly plenty of studies that show we're starting to get close to the total in terms of survival. Why do a uni? Why would you choose that? Or why would a surgeon like doing it over the other? One, it preserves bone stock. When we're doing some of these surgeries in patients in their 50s and even 60s, and we're all living longer now, hopefully a lot of us are going to make it well into our 90s, there's a good chance, no matter what you have, a partial or a total, it's going to need to be revised. And when you revise them, you have to take out the implant that was put in. Well, a total knee, you're going to lose much more bone stock, and that will result in a more complex revision. Many times if a person goes 15, 20 years and has to have it revised, it's much easier to do a uni to a total, and studies have shown that the results are better there, because many times you can do what we call a primary total knee. In other words, the same type of total knee the person would have had if their first operation had just been a total. When you revise a total knee that's already been done after 15 or 20 years to another total, oftentimes you have to use stems, you have to use augments. It's a much more extensive operation because it's harder to get out. So, preserves bone stock. It's less surgery. It's the only truly, I think, minimally invasive knee type replacement. Not only is the incision smaller, we do not disrupt the normal sliding mechanism under that large muscle in the front of your thigh, the quadriceps. And that's very helpful. Uniformly, over the 30-some years I've been in practice, my unicompartmental knees get much better range of motion than totals do. And I think other surgeons notice the same thing. It's a quicker and easier rehab, and if you do have to ever convert it to a total, it's much easier to convert a uni to a total than a total to another total. Richard Berger, a well-known knee surgeon, looked at his results on this one side. If you look at this classification system where we're using a rating system to rate whether it's excellent, a good result, a fair result, or a poor result, and this is an outstanding surgeon, on his partial knee replacements, 82% excellent, totals 57%. So he had more excellent results by 30-some% more with his unis than he did with his totals. And I've heard him talk before and say those are his best results. But he has outstanding results. I mean, even in his totals, his combination of excellent and good is 87%. Over here it's 85, excellent and good, but much more excellent results. When he followed those up, the results held up. 15 years, 82% had excellent rating, which he clearly states did better than his total knees done in the same period of time. This is what I feel about when you're thinking about these surgical options. I think there's a need for a pre-total knee surgical procedure, something that is gives the patient an option. In other words, they've tried the pills, they've tried injections, they've had bracing, they've went to therapy, they're having problems. I think arthroscopy is worth considering. Some controversy there, but I believe that it really can keep a lot of people going and give them a chance to prolong the time when they would need some type of replacement. And I certainly think the partial knee replacement is certainly a good bridge that for many people we're looking at 15 to 20 years of a much more natural knee with quicker recovery. And if it doesn't work out over time, you've certainly got a device that has a lower infection rate, lower complication rate. And the truth of it is, osteoarthritis is really, in my experience, and a lot of other doctors, it's a unicompartmental disease. It's highly segmental. It'll affect one part of the knee much more severely than the other. So if we can just replace that portion and balance out the knee, for a lot of those patients, that's going to be a good option for them. Osteoarthritis is slowly progressive, so if we can balance it out, that other part of the knee may have the similar arthritic process going on, and it may progress over time, either in the kneecap, underneath the kneecap, the patellofemoral joint, or on the lateral side. But it's slowly progressive, and it can be relatively stable for a decade or more. What do I like about it? You minimize damage to the joint. The more you can keep the ligaments, the more you can stay out of that suprapatellar pouch, that area underneath that powerful muscle in the front of your thigh, the quadriceps. If that gets bound down to the femur, it's going to restrict your ability to flex the knee. So with the uni, we can just do a minimally invasive procedure and balance out the joint without tying up the quadriceps, without sacrificing any ligaments. I think it certainly minimizes the interference in lifestyle. I just see that people can have it done, some as an outpatient, some go home the next day, and much quicker rehab, I'd say at least half the time, with a higher percentage of excellent results. And if you need treatment options in the future, you still have the option of a total knee with minimal difficulty doing the revision in most cases. This is what I was talking about, a little schematic drawing here. This lower part here is to represent the tibia. This is the femur or thigh bone. A large muscle that we can all feel in front of our thigh connects to the kneecap. And this so-called suprapatellar pouch is a normal fold that is disrupted when a total knee is done. That binds this down, and you need about 4 times. You need elasticity of this thing to stretch out to 4 times its length in extension for flexion. And when that contracts down, you get tightness in flexion. Here's some other studies. John Rapisi has been a pioneer in Buffalo, New York. He's a surgeon in that area. He's done a tremendous number of total knees. I know at one time I heard him talk, and he was doing up to 700 a year. He predominantly did partial knee replacements. And you can see the wide range of patients. This is one series we took 136 patients and followed them, age from 49 to 80, mean age of 66, and a wide range of weights. I mean, most of us would be a little afraid to venture into doing a partial in someone that heavy, but it can be done, and I think the patient and the doctor have to understand the risk and the likelihood of that affecting, or in a negative way, the risk of loosening. So what was his results with these patients? He had a 96% survival at 8 years, and most of the studies we look at are going to be in the 90s when you get out 10, 15 years. And that all-back classification we looked at, those 2s and the 3s that he did, which was the ones most of us would think is appropriate, even when he stretched it to the more involved ones, those were lasting 8 years. 75% of them were lasting. So the surgical technique for a total knee is a much larger incision. That's not the most important thing. I think it's probably the least important thing. But we do have to go up and disrupt that quadriceps mechanism, that muscle, that sliding suprapatellar pouch. much larger bone resection. We're losing more bone. If you ever need a revision, then you've got more options with the partial. Oftentimes, you're always losing the ACL in a total knee. That's one of the four major ligaments. That's one of them. A lot of doctors start with what's called a PS knee, and they'll lose both the ACL and the PCL if we sacrificed. And those ligaments provide stability to the joint, but they also provide what we call proprioceptive or position sense information to the brain, kind of to tell you where you're at. So that's, I think, why a lot of times, if you ask people if they've had a total knee on one side and a partial on the other side, we'll say that the partial is a more natural feeling knee because you get that input from those ligaments. And the alignment is not as true with the total as I feel it is with the uni. So it's a smaller incision. There's no muscle trauma. There's minimal bone resection. You retain all your ligaments. In addition, recovery is quicker for the vast majority of patients. Time in the hospital for our total knees right now is running around 3 days. For a uni, it's about 1 day. Most patients with walking aids are requiring it for about twice the length of time with the total as they would with the uni. Some of these patients within 7 to 10 days can actually be on a cane and then off the cane within a short period of time. It's much more extensive physical therapy. You're probably looking at 3 months compared to a month. In terms of what you'd call recovery, and that's sometimes a hard thing to describe, but I would say 6 months, if someone asked me with total knee, to really kind of complete the recovery in terms of the healing process, doing the therapy, and getting to a point where you're kind of getting close to maximum recovery. For a total, I'd say 6 months, and certainly at a year, we're going to still see improvement in that 6 month to 1 year period. Usually within 3 months, a uni is pretty much there. Gait studies where they observe how people walk, we see a much more normal pattern with the partial. Stair climbing is less of a challenge because we haven't disrupted that quadriceps muscle mechanism as much.
Okay. We've got some questions that were submitted ahead of time, and we will answer those now. Can I be helped if I have arthritis? I had a scope a year ago to repair a tear.
Okay, so they were saying they've had a scope.
They had a scope a year ago to repair a tear.
They also had arthritis.
They now have arthritis and are curious if they can be helped.
Okay. Well, certainly. I mean, as I tell all my patients, first you'd want to know sort of the extent of the arthritis. Is it mild, moderate, or severe? How much joint space narrowing is there on the x-rays? What did the doctor see at the time of the arthroscopy? Is it primarily limited to one compartment of the knee? And then the other question is, I often explain to patients who get an MRI and it shows they have a tear. If they have a tear and they have no arthritis, you're going to get a much better response from the arthroscopy than a person who has a tear associated with arthritis. So I think it's important to explain that ahead of time. But yes, there are things you can do, and those broad categories are pills, in other words, anti-inflammatories, Motrin, Advil, Aleve, or one of the 100 different prescription items available. I have a lot of patients that we manage with occasional cortisone shots. They don't like taking the anti-inflammatories, or it bothers their stomach, or they have compromised renal function. So a cortisone injection 2, 3, 4 times a year can often help manage a lot of my patients. There are these gel injections we use called viscosupplementation, something I think you ought to explore if the meniscal problem's been dealt with and you're still having discomfort from the arthritis. I would certainly talk to my doctor about viscosupplementation. You hear the names Synvis, Supartz, Orthovisc. Bracing, I think too often we forget about braces. They can be helpful, allow you to, I mean, really when you think about it, what makes a person happy? One is to be pain-free and to function at the high level they expect for their age. So, you know, if the knee functioning doesn't allow you to get back to, say, playing golf or tennis, perhaps a brace can help you. Physical therapy is an important part. I think too often we ignore how effective strengthening the quadriceps muscle and the hamstrings can be. Many studies have shown that. But you need a good therapist to kind of get you started on the right program. Too many folks, I think, go to the gym and just find a piece of equipment and they see some college kid doing it and they decide they're going to strengthen their leg too, and they stir things up more than they help. So you need to do the exercises properly. And then you get into, if you do have a knee and the doctor who scoped your knee says that you have advanced arthritis in one compartment, then the total versus partial discussion comes up, and hopefully we've highlighted some of those elements for you tonight.
Thanks. When is the right time to have knee replacement surgery?
Well, that's something this is my 37th year of practice, and I've never come up with a real good answer for that. You think I would have it by now. It's really such a personal decision. I think the things that I would think about, I think a person should think about, and it's not a hard and fast rule. If at a certain age in life you realize that you may have some health issues and you worry about them progressing over time, and you think, well, geez, if I hang on another 5 years, if you have a knee where you have enough arthritis and enough pain that it merits consideration of a knee replacement, what do you gain by hanging on for 5 years more? You may get to a point in life where your internist is not going to clear you to have the surgery, and then you're kind of stuck, and I've seen that over the years. In addition, during those 5 years, what was gained? I mean, I think at a certain point in life, if you've been told you have arthritis and you've been told that it's at a point where knee replacement's warranted, I think at a certain point I tell people, either do it now or just decide you're never going to do it. Because I see people who sort of split the difference and they end up getting knee surgery after they've hung on for 3, 4, 5 years, and the deformity has gotten worse. The capsule and soft tissue has gotten stiffer. Now they're not going to have as good a result, no matter who the surgeon is, because of these secondary changes. So I think there is sort of a prime time. I think it's something you can discuss with your surgeon. But one way I explain it to patients, I go, if your knee has become your boss in a way, it tells you what to do. It tells you, how long you can walk you can't go out and exercise. You can't enjoy some of the activities you used to enjoy, whether it was golf or tennis or going to the health club or just going out with your friends for an evening or going on vacation somewhere where there's some walking involved and you're limited. Then I think it's time to give serious consideration to a knee replacement.
Okay, I have pain in my left knee when I run, yet if I walk at a very rapid pace, I'm okay. Any idea why this might be going on? By the way, I once tore a meniscus and it feels similar to that.
Well, it's an interesting question. I'll speculate. I mean, and as I should say before I answer any of these questions, whether it's on the internet or on the radio or whether it's a webinar, you need to rely on your doctor. I can give you some general thoughts. For a person who does a high impact, the difference between running and walking is the impact, is that you sort of jump forward and land on that leg when you're running. While walking, you're balancing it between the two legs, so the sudden impact is less. What helps absorb that high impact in a younger person is they have healthier cartilage and they have a healthy meniscus. So a torn meniscus could certainly lead to higher pressures in your knee when you do high impact activities like running. So I think it would warrant consideration of an MRI. Arthritis itself could provide a similar difficulty to try and run and absorb high impacts because you don't have the cartilage there.
Okay. I've had recurring knee pain over the years. It is now constant. X-rays and MRIs do not reveal anything. Physical therapy also did not help. I have not had gel injections yet. Not rheumatoid arthritis. I'm only 53, but I move like a 99-year-old. What should I explore next?
Well, let me just dance around that one a little bit and answer it this way. Most of my talks, I start out with these 3 questions I want to answer for my patients. In other words, what's the problem? What's wrong? What can you do about it? How's it going to turn out? So the first question, what's wrong, is a diagnosis. Now, from what you're saying, you seem to have the feeling that your x-rays look perfect and your MRI doesn't show any problem at all. So it does make you start to question, do you have a knee problem, or do you have a problem somewhere else that's causing you to experience pain in that region? The one area we see miss the most is the hip. I've had patients who thought their primary problem was their knee, when in truth they had developed arthritis in the hip and it was being referred to the knee region. The other area is the back. Occasionally I see patients who have some arthritis in their spine, maybe some stenosis, maybe a disc problem, and it's generating pain in the region of the knee. The other thing is, it might be good to have another discussion with your doctor about, is that MRI? In other words, I see patients sometimes and they've kind of had the impression everything's okay, but I look at their MRI, well, they don't have a torn meniscus, so maybe the doctor was looking to see if there was a torn meniscus, so in a shorthand way he just kind of said, oh, it looks okay. But if you really look closely at the MRI, you'll see on some of the settings the thing called bone marrow edema, which suggests arthritis, where you're overloading the bone and causing high pressures in that area. So I think it deserves some more explanation to be certain you're treating the right thing. So before I do the gel injections, I mean, my feeling for doing those gel injections, or what we call viscosupplementation, is you need a patient who has arthritis in their knee. So I think that needs to be nailed down as part of your problem.
Okay, why is it when I kneel in my knees it hurts and I cannot stabilize myself?
Well, kneeling is one of those activities, puts a lot of pressure on different parts of the knee. Certainly, I have patients with arthritis who kneeling is very difficult. The stairs are difficult because when you kneel or when you go up and down stairs, you put a lot of pressure on the back of the kneecap. You also put stress on the back of the tibia, particularly where the meniscus is at. And sometimes if you had a torn meniscus, either from an injury or just from age, what we call degenerative tears, those could be responsible. So again, trying to make a diagnosis. In other words, what is wrong? I mean, what you're talking about basically is a symptom. The symptom is that when you kneel, it hurts. What causes that? Well, that needs to be explored through an X-ray and a physical exam and possibly an MRI.
Generally, how long is the recovery time after surgery for a partial knee replacement and a total knee replacement? And does that recovery time cover or include physical therapy?
Well, to give sort of a brief, an average, I mean, it's sort of like saying that the average man is, I don't know, 5'9". We know there's people 7 foot and people much shorter. So, but some of the numbers I gave in the talk, I think, are reasonable estimates. I would say that it's probably at least it's 6 months for a total knee. I would say more in that 6 to 8 week period for a partial knee replacement to really kind of get going. Now, I know there's some patients that have had partial knees that have struggled longer, but I'm talking about the average, what I've seen over 30-some years of doing this type of surgery. So I think it's a much quicker recovery with the partial. Now, certainly after 6 weeks, if you look at the person with a partial at 12 weeks, they're going to feel better than they did at 6, certainly. the person who had the total knee at 6 months is going to feel better at 1 year. But in general, I would say it's about half the time. So it's supposed to be evenly distributed on both. I would say 6 months for a total and around 3 months for a partial.
Okay, our last question is a spin cycle class a good form of exercise for older adults?
Well, again, my usual disclaimer, I wouldn't want anybody with a bad heart or other health problems. But in general, because tonight we're talking a lot about knees, and I assume you're kind of asking an older adult with some knee problems, I think that's, for most patients, excellent. In other words, if a person had arthritis, didn't have a significant torn meniscus that was catching in the joint, I think a stationary bike is an excellent way to do it. The spin class thing, I think, is just a way to kind of, I suppose it helps. I've never been in a spin class, but from what I hear, you've got some motivation going on. There's nothing wrong with that. I know I could use some when I go to the gym occasionally. So yes, I think in general, and again, you have to take everything in particular. If you have someone treating your knee, you certainly want to ask them. If you have a torn meniscus, he may not want you doing it. But I think if you set the stroke right on the pedals and adjust it, put it this way, if I had arthritis in my knee and I wanted to exercise and try and maintain cardiovascular fitness, I think that would be an exercise I would certainly consider. So I guess the answer is yes, with a few modifications for your own particular situation.
Okay. Well, we'd like to thank everybody for joining us this evening, and thank you again for all the submitted questions. Take care, everybody.